Good morning, everyone. Thank you for this opportunity. I am going to present a talk entitled, and to answer the question, if intraoperative fluoroscopy significantly improved the acetabular component position in a primary THA. So for a successful THR, obviously the acetabular position is critical, and generally this safe zone is well accepted between 30 to 50 degrees of inclination and 5 to 25 degrees of anteversion. And we wish to assess if the use of intraoperative fluoroscopy would provide better version and inclination of the acetabular component. So this was a prospective and randomized control study, a prospective study done at MGM Medical College, where our study groups were randomized after ethical committee approval. We had 120 patients in this study that were all operated by a senior consultant, and 56 patients were operated with fluoroscopy assistance, while 64 were operated without any fluoroscopy assistance. All patients were operated through a posterolateral approach. The C-arm was draped and inverted such that it could be brought in from the foot end of the table to facilitate ease of surgery, and we took C-arm pictures after trial placement and after final component placement, like this, in which the inclination was calculated approximately just by the position of the cup, and the anterior and posterior borders of the cup were clearly seen to conclude that the cup was anteverted. Post-operatively, we calculated the version and inclination on a PBH AP X-ray by these two methods described by Liu et al. And Wu and Mori, and we had to exclude 14 patients due to poor post-op radiographs. So this was a method that we used to calculate the version, and it says sine inverse of tan beta, but it's not very complicated. This paper was originally given in 2006, and it was shown to be the best method to calculate version on a PBH AP X-ray and comparable to CT-based methods using software. So the angle shown in this is the beta angle, and I'll briefly describe how it's to be calculated. A straight line is drawn from the two ends of the cup where they are still perpendicular to the line. One side of the ellipse is drawn along the shadow of the cup that can be seen behind it. Identical opposite ellipse is drawn and a perpendicular is dropped to it, and when any one end of the cup is connected to it, this angle becomes the beta angle. It's quite easy to draw, and it can be easily done even in things like paint. So the sine inverse of this is the beta angle, and it's been shown to be the best method to calculate version. Inclination is relatively more straightforward. A line through the ischial tuberosities and the cup gives the inclination. So these were some examples from our study where this method was done for all the patients. And coming to the results, what we found is that the mean version and inclination in both the fluoroscopy and non-fluoroscopy groups did not vary significantly. There was no difference. However, the standard deviation and variance from the mean was much higher in the non-fluoroscopy group than the fluoroscopy group, and a significant difference was seen. 9 out of 58 patients were outliers for version in the non-fluoroscopy group and 15 out of 58 for inclination, while there were no outliers for version in the fluoroscopy group, and again this difference was statistically significant. As we can see the box plot here, much more variability in the non-fluoroscopy group compared to the fluoroscopy group, and the same for inclination. To quickly review the literature, in a study in 2014, when they were using intraoperative X-rays to optimize component position, they found that the problems identified on an intraoperative X-ray could be rectified in 97% of the patients on table, and only 1% had suboptimal positioning on post-op X-ray if an intraoperative picture was taken. And in another study that was comparing anterior hip arthroplasty with fluoroscopy versus posterior approach, they found that there was a significant improvement in cup anteversion using fluoroscopy. The limitations of our study are we didn't correlate our findings with actual clinical outcomes, or we didn't measure any other parameters like offset, limb length discrepancy or stem alignment, and we didn't quantify any increased risks or time added by fluoroscopy, and we are currently conducting a larger study for these problems. So we concluded that intraoperative fluoroscopy significantly improved the version and also definitely reduced the number of outliers for both version and inclination. And we felt that considering the scarcity of resources and lack of access that we have to any specific technology, use of methods like this are cheap, easily available in all operating rooms, and it protects both surgeons and patients from malposition. Thank you.